Where are you seeing HIE data make the biggest difference today in care or operations?
I'm going to answer a little bit and then kick it over to Bruno, since he's actually also providing direct care. A lot of what I see with our hospitals is around coordination of care and helping with ensuring that folks can find other providers, case managers, care managers, and that they can see information that exists from other providers. That's certainly one of the big areas. We also have some work that we're doing to try to help ensure that providers are able to access the information while they're providing care. But with that, I'll kick it over to you, Bruno, because you're actually more in that space than
Sure,
me.
I'd be happy to. Actually, I'm going to ask the audience, raise your hand if you or a family member of yours has ever been in the emergency department before. All right, that's basically everybody in this room, no surprise there, right? And what if the emergency medicine physician walks into the room and says, I see that you presented at another hospital 6 months ago with exactly the same complaint. And these are the tests that they did, and this is what they found. Wouldn't you feel more comfortable knowing that your physician has that piece of information and is now able to have a starting point of where to start with your medical care? I'm an emergency medicine physician. I pick up a chart electronically. I go into the room. I have no idea what I'm going to encounter. Some of our patients have never been to the hospital before. Some of them, it's their 50th visit over the last 5 years with the same chief complaint. And I'm able to then go into CRISP and then find out what's been going on with this patient over the last 2 years, 3 years, 2 weeks ago, whatever it was. You know, I work at George Washington. There are many Georges in Washington, D.C. You know, patients insist all the time, you saw me just last week. I'm like, well, actually, that was Georgetown, or that was Metzar Washington Hospital Center, right? So we get this all the time. And what we're then able to do is still access that care of those patients. Understand, what did that CT scan show last time, right? Did it show a little bit of a pneumonia and now I'm worried about more pneumonia? Did that blood work show some abnormalities that I should be aware of that will impact your clinical care this go around? So having access to all that at the fingertips is really important. And we'll kind of get a little bit later into some of the questions of how we got to where we are. And I think that journey is clinically very important also.
I agree. It has certainly been a journey together with everyone at this table, which is something that we take pride in. Again, being a nonprofit driven by people who are on our board, such as Bruno, and partners and stakeholders, and sometimes sub-grantees and partners in the work, sitting shoulder to shoulder with providers to understand exactly what their needs are and how we need that data to get to them. So another thing about us is we are completely vendor agnostic. And in the district, actually, there are a lot of different vendors that serve our hospital systems, and especially a lot of vendors that serve our behavioral health providers and our FQHCs, and we have to make sure, regardless of what that vendor is, the data is flowing, and that has been one of the biggest barriers. In some places, there is one vendor that has the market of all the hospitals. That is simply not the case in DC, and it doesn't look like it's going to be moving that way anytime soon. And so that's what makes where we sit as this neutral convener so important. I do want to highlight that one thing that is also in the HIE is over 350 ambulatory organizations are also sharing clinical data. So that means they're sharing those CCDs, ORUs, those discharge summaries, those PDF-like documents that have everything from a visit, from your medications to your diagnoses to your summaries. So it's not strictly just the discharge from hospitals where people think HIE is kind of sad and lived for a long time. We are getting in that ambulatory data as well. And so in Bruno's example, he could also say, you were just at your primary care provider and they ordered that imaging because of these symptoms. And that could potentially, again, help him triage more quickly how he's managing his patients. So I do like to highlight the fact that ambulatory connectivity is one of our biggest work streams. We've had the hospitals connected since we entered the district in 2017. Actually, we were working with them since 2013. We've really kind of grown beyond that, and that's been a big focus of our mission in order to support the hospitals in their transition of care when people are going into the hospital and also when they're coming out. So Gail, I don't know if you want to kind of dive into what you've seen as kind of a convener of all of the hospitals on how access to more timely and connected data has changed how your teams work and the teams you work with at the hospitals when it comes to whole person care.
Sure, and some of these are similar to the example that Bruno brought up. One of the things as a convener that often happens with us is we have a group of care coordinators or physician leaders that are getting together to try to figure out how to improve quality of care. And so they will ask us, can you bring the Medicaid agency to the table? Can you bring CRISP to the table? Can you bring the ambulatory providers to the table so that we can get that information and be able to use it at the bedside when someone comes in? And that really has ramped up since 2018, 2019. We've been doing a lot of work in that space, trying to make sure that that the information is available at the bedside when it's needed. And so this has focused on what I would sort of say are two tracks. One is the digital exchange of information. How do we make sure when somebody sees that primary care provider or discharges from the hospital that that information is flowing to the health information exchange in a timely way, and that the information is then served up and made available? And then how do we make sure that the workflows at the organizations, particularly for us, the hospitals, are set up and facilitated so that there is a protocol and some natural flow in place so that you have reliability, that it's not just Bruno, who happens to know the HIE and know where to go look, that can go find that information, but there's some standards so that all of the physicians have some understanding of what's in the HIE, how that clinical information flows and where to go find it, that the care coordinators consistently across organizations and hospitals know how to get that information. And so through that work, one of the things that we've done is gathered information, you could call it use cases or stories, and then when we help facilitate training, we take those examples so that it's not just a training of, you need to go into the EHR and click here, click here, click here, and you can find the information. It's, oh, you have a patient in front of you that's presenting with XYZ. Let's think about that scenario and where you could go to find that so that there's context to that. And so a lot of the work that we've been doing in convening folks has been on trying to help figure out how to integrate this into their workflows so that the information is flowing and then people are actually able to use that information while they're delivering care. To ensure that, the point of this whole thing, whole person care, that our organizations that we work with are able to contribute to that. I could go on about this for hours, but I'll shift it over.
That's fine. I guess I'll ask the audience another question because I'm interested in what you guys do also. How many of you are worried about building IT bridges amongst the different component or organizations that you provide care with? Allowing data to flow between you and other organizations. Do you guys spend time working on that? Looking at your clinical integrated networks, your ACOs and things like that. And we have the same kind of approach also. And it's great to know that we can fall back to CRISP, right? Why do we have to spend all the IT time to build bridges amongst different systems and processes if the information is already there in CRISP? And clinically, that's important. I want to highlight also the quality component of this. I was working in the emergency department a couple of weeks ago, and we had a patient who came in with a very concerning presentation for really badness. And, automatically, well, this patient definitely needs a CT scan to make a diagnosis or refute the diagnosis of this badness that the patient was presenting with. Well, as we were looking then through CRISP, we realized that this patient had presented with the same presentation many, many times, and I had over 100 CT scans done in the last 3 years. And that allowed us to then, really take a step back and say, what are the odds that on this 101st time this badness actually exists if we've already looked 100 times? And this is where we can, again, leverage CRISP, go back, have that discussion with the patient, really understand what's going on, and in that particular case, avoid unnecessary radiation to the patient by doing yet another CT scan that seems very indicated, very necessary, but we're able to really do that deep dive and get that history.
It's interesting you mention that because some of the examples that we have through the work that we do looks at how you work it into your own clinical workflow, but also how you avoid duplication of effort.
Yep.
And if you think about that from a broader perspective, how you avoid unnecessary cost and unnecessary exposure or suffering when it comes forward. And that's something that we've seen, time and time again. The other thing that Stephanie said that I want to emphasize with this, that's something that, as a hospital association, we're here to advocate for the hospitals, in a large degree. That's sort of our role. And one of the things that is important to them, if I am on Epic and I'm not changing, to Cerner, I'm on Cerner and I'm not changing to Epic, or I'm using a certain software in order to facilitate care coordination, I may not want to change to something that's standardized. And the fact that CRISP has remained vendor agnostic has actually been very helpful for the organizations, because it allows them to use the systems that they have in place and still look to achieving that integration with technical assistance and support from folks like CRISP, ourselves and others, try to help make sure that we're able to facilitate that information exchange, which has been a real benefit in the district. That I know in other jurisdictions are sometimes a challenge.
One thing I do want to highlight that we found that is very important is we share the images themselves. We do not just strictly share the reports. So in the use cases that you've heard Bruno highlight, and I'm sure you all can think of many, probably personal ones. I had one with a family member this week where I had to beg a provider, please check in CRISP. I know they were in a different health system, but they did have imaging more recently than February that you can compare to what you're seeing now. And it's important to have that imaging and rather than a report when you're looking at certain diagnoses, and so that's why we've made sure we have that enhancement in our platform. So Bruno, you spoke a little bit about the journey of how we got here with CRISP, and Bruno's been working with CRISP and a user of CRISP longer than I've been at the organization, but if you wouldn't mind talking a little bit about that journey and what's different today versus 2, 3, 6 years ago, and how that data shows up to providers and maybe how that's in the workflows today.
Yeah, no, I think that's important because ease of access is so critically important, right? You can have the best library, but if you don't want to walk to it, then you'll never read that book. And the same thing is also with CRISP. When we started off, CRISP was a separate login. I don't know about how you guys manage your logins. I've got tons of different credentials to log into different websites. I won't tell you what I personally do because otherwise you'll all figure it out. But 1, 2, 3, 4, 5 with an anyways. But that being said, it's really important to have that ease of access. So what we ended up doing is actually embedding it into our electronic medical record in our facility, which means if I'm in the electronic medical record of a patient, I just need to toggle to click, and I'm in that chart in CRISP for that patient. And that allows me to have immediate access. Again, I'm an emergency medicine physician. I have short-term memory in everything that I do. And so being able to see like a discharge summary from a patient before, that's just so interesting and helpful to help put everything together. So as we have put in more information into CRISP that is easily accessible, and we're working on even more accessibility of that information with different filters and things like that, so that we're really able to leverage the information for different medical audiences. Because if you're at your cardiologist, they want to know what's your last echo, what's your last stress test, what did your last cath lab test look like, your last EKG, versus if you're at the orthopedic surgeon, they want to know, your x-rays of your right hip over time, and is it now time to replace that hip or not? So leveraging CRISP, not just for the data that there is, but also the accessibility, I think is key.
One of the things I'll add to that, hopefully you wanted me to answer this question.
Yes, absolutely.
One of the things that I've noted is very different is actually that expansion into a broader space. When I first started working with health information exchanges, they were more hospital focused, and certainly that was the case with CRISP. And one of the things that we found as we started to explore this further was it was that sort of which one comes first, right? There's this balance in building a system where you have information in the system so people will use it, but it's not quite enough information, so they don't want to go in the system, but you get more information and you kind of have to build more information, more users, more information, more users. And having the ability to build into this system, not just hospital information, but information from outpatient providers, from behavioral health, from SUD, has really been, I want to say, when did the universal consent process come in? It actually wasn't that long ago, but it really makes it's a game changer when it comes to how you would make sure that someone is able to consent to have their SUD information or substance use disorder related information in the system, as an example, in a way that is much more universal, which allows many more providers to see that information when it's critical to clinical care. And so for me, that has been a big game changer, because it has not only made the information that is available to folks like Bruno more rich, but it has actually fostered that building block to get more users, more information, more users, such that now we have a digital platform and tool that is more universally accepted and used, which just builds on its utility.
Thank you for leading me into my next question, Gail. And again, to highlight a little bit about what we're doing. So we really have plateaued at this point, roughly. There's obviously new organizations entering the district all times, and organizations changing hands, and connectivity for both ambulatory organizations and obviously the district hospitals. We're always updating feeds, but now we're looking at getting more robust data in there and building on the data we have, like Gail said. So my next question is for, to help Gail kind of discuss some of the work we're doing in partnership with her, but where is expanding data beyond traditional clinical data like behavioral health and social needs data starting to make a difference? And what type of new data are you seeing make the biggest impact in some of your work outside or adjacent of the hospital associations, such as the Perinatal Quality Collaborative and other work we're partnering with you on in the district?
Great tee up. I did mention the substance use disorder related work. We do a lot of work with the hospitals in the district on opioid response and trying to ensure that we have good, strong programs to implement best practices, and making sure that information is available to providers at the bedside and to outpatient providers when permission is given is critically important. Another big space that we've really seen a lot of uptick is in, as you mentioned, the maternal health space. We run the district's Perinatal Quality Collaborative, and right from the get-go, as soon as we started talking about postpartum and coordination of care, folks came to me and said, how do we get this in the information exchange? How do we get it so that the information that we need is presented in a way that's easy for us to find as maternal health care providers? How do we even get alerts? If something happened at the hospital that we might need to know about, how do I make sure that I know that that's happening, so that when I am meeting with my patient, I understand what may have happened, whether they had a hemorrhage or, sadly, let's say they had a stillbirth. The last thing I want to do as an outpatient provider is say, so how'd it go? And then you're stuck in a very awkward conversation with a patient that you're supposed to have a really good, strong, trusting relationship with. And so we've worked really hard to make sure that we're connecting the dots across the continuum in some of the functionality that's available through CRIS, so that we can make sure we're facilitating that kind of positive exchange of information in a more digital world. I don't know if you have.
No, I think you said it great. Thank you.
I kind of wanted to go next. In a way, we've been highlighting some of the great work that we do, and I'm certainly very proud of that, what we're doing around the consent tool. I believe there's only one other state in the country that's sharing substance use disorder data. We have a consent tool that allows the explicit consent from a patient to share that, because there's an additional layer of consent needed on top of HIPAA based on 42 CFR Part 2. So we made sure that we were able to do that. And again, I think highlighting all of the work we're doing is great, but obviously the system is not perfect, and what we do is not perfect. And so, and I work with both of these stakeholders in their capacity to be critical of the processes that we have and how we can get better. So my next question would be, what's working to drive adoption? What's not? What can help clinicians actually use the data available to them? As we heard at the beginning, it's not enough to just have a library full of books. You want people to go there. And so what are some steps that we can take, steps that we are taking to make sure this data doesn't only exist, but that it's being used on the front lines?
Yeah, What do I want to talk about most? I don't think we were going to
Yes,
talk about that.
absolutely, yeah.
So, as you know, end-of-life care decision-making is very important, right? And there's a way now within CRISP for providers to go in and actually document the patient's wishes and desires within CRISP. And that's something really important because it transcends, again, all access points of care, from primary care physician to hospital to, a skilled nursing facility to, any other urgent care you might go to or whatnot. So having all that information in one location is really key. I think the way that we have it really is that it continues to, again, be accessible to providers. I'm sure many of you in this room have a healthcare proxy, you might have a power of attorney and things like that. Just like mine, it's locked in my safe. That way my kids don't get my power of attorney and sell the car. But all these things, that we do, we need to have it though accessible in the moments that you need it, and locked away in a safe really does not work. So having access to those libraries, again, those books that we're trying to get access to, let's find the right chapter, the right page at the right time. That's really important and critical. So there's so many facets, right? You've heard about, truancy in the school system, about immunizations, around molds, around x-rays and images, around health information, discharge summaries, cardiac catheterization reports. It's really this tremendous library, and it's a way that we can all access it. And again, it's about quality of care that we provide. It's around timely use and appropriate use of resources also. And I feel that the HIE really gives us those tools to be able to do that. On the clinical side, I think it's important. There are some financial components in it also, right? And that I may not have to repeat this study because it was done recently and we're all very comfortable, and we can have that conversation with the patient around what that means in their care, because that's the most important piece.
I think I'll build on that. Something you said struck me. A lot of what we do at our organization, and now we have a group called eHealth DC, that's a group of partners that are working to help organizations and providers adopt the technology. Some of that work we were talking about with respect to improving the transmission of information, improving the adoption of the technology. But one of the things that struck me as you were talking was trust, right? And so one of the things that I know we ran into early on as we were trying to think about how to exchange health-related social needs was, just because somebody did a screening on health-related social needs and it's in there doesn't mean that I, as a provider, don't feel like I need to do that now, because I might ask the question differently, or I might need some nuance of information. And so I think working through whether it's a social needs use case or some other use case, around making sure that we're working with providers to build that trust. If they see information that's available, that they can understand when they can trust that information and use it, and when they might need to redo a study or a screening of some sort where it might be clinically appropriate. I think that's something that's not the digital aspect, but it's something that is going to drive how well we're actually able to adopt the technology when it comes to whole person care and care by the bedside. I think coupling that with some of the things that you've been working on with respect to getting those social sort of needs providers, like those who work in the food as medicine space, into the system, and working on some things around closed loop referrals has been very helpful, because it reinforces that community and that exchange of information beyond just, let me go in and check the history and then move on with my life.
One thing I also am very proud to highlight is all of the participation in the HIE in the district is completely voluntary. So we've gotten this far through building trust with the community and the stakeholders that we work with. And again, we're really proud of that. That another recent use case of where trust became the topic of discussion, and honestly at the forefront, was sharing substance use disorder data and going live with our consent tool to do so, and how our infrastructure supports that. And so again, that really ties back to the fact that CRISP DC is a mission-driven organization. And as a nonprofit, we are here to respond to the needs of the district and make sure we do so in a way that puts their needs at the forefront of all of our decision-making as a business. So